solemnly swear or affirm the testimony you're about to give shall be the truth, the whole truth, and nothing but the truth, so help you God. Have a seat right up there, please, ma'am. Once you're seated, I need you to speak. You state your full name, spell on your license.
Come on.
Morning, Dr. Kruse. How are you doing?
Good morning. I'm well, thank you.
Just want to ask you some questions. What do you do for a living?
I'm a clinical neuropsychologist. Would you like me to elaborate on my history?
Well, I tell you what, how did you become involved in this case?
I was contacted by Dr. Frierson. You saw him testify, I believe it was last week. He asked me to perform a psychological assessment or gather additional information objectively to help him with differential diagnosis and to conceptualize the defendant.
What is a neuropsychologist? Or what is neuropsychology?
Sure. So it's the field, it's a scientific field of neuroscience with practitioners who develop and use testing to help people understand brain behavior relationships. So not only the psychology or behavioral aspects of how someone functions, but also neurocognitively or their thinking abilities.
And what's your educational background?
So I have a doctoral degree in clinical psychology with additional training, postdoctoral training in neuropsychology. I'm originally from Florida. I went to University of Central Florida with my undergraduate degrees. I have a double major in psychology and sociology, and then I completed my doctoral degree in Florida through the American School of Professional Psychology, Argosy University in Tampa, and then I went on to do my residency or internship in Maryland with the John L. Gildner Regional Institute for Children and Families, which is affiliated with Johns Hopkins, which is where more of the medical or neuropsych side came in.
And what's your professional background since you've been practicing?
Yeah, I've been the chief neuropsychologist and a hospitalist at Prisma Health for 11 years. I'm also affiliated with Kershaw County Hospital System and Compass Health, which used to be Health South. And so on a day-to-day basis, I'm performing differential diagnosis. I'm using psychological testing instruments, neuropsychological testing instruments to determine if patients meet criteria for psychological or neurocognitive disorders, and help in terms of planning for prognosis and discharge from the hospital or admission to the hospital.
How many evaluations have you performed?
Thousands.
How many times have you testified as an expert in a court of law?
I've been qualified in the South Carolina judicial system approximately 75 times as an expert in the field of neuropsychology, and that would span across civil, criminal, and probate court matters.
Your Honor, at this time I offer Dr. Kimberly Kruse as an expert in neuropsychology.
Board Dyer, please.
No, sir.
All right. Dr. Kruse is qualified field of neuropsychology. She may offer opinions to that end.
Dr. Kruse, you mentioned that Dr. Frierson asked you to get involved in this case. Now, he's a psychiatrist.
Correct.
Right. So your fields are obviously a little different. What exactly was he asking you to do in order to assist him?
I've worked with Dr. Frierson for a few years now. My role would be to assist in guiding his clinical opinion by providing objective data. So clearly he did, I don't even know how many hours of research going through history, various forms of history. But he would encounter to, I think, or just to complement or look at psychological testing data. He did have that as part of his review, and it didn't seem to make sense to him. And so from my perspective, my role was to perform similar evaluations to look at how the defendant measured up in terms of intellectual ability, cognitive and behavioral functioning.
And did you have an opportunity to do an evaluation on Mr. Jones?
I did.
What day was that?
February 22nd, 2019. It was a Friday.
So it's just earlier this year.
Correct.
Now, did Dr. Frierson do the introduction with Mr. Jones?
He did.
And he agreed to take this test?
He did.
And did you go through with Mr. Jones the purpose of the testing you were going to be doing?
I did.
And what you've talked about the general approach that Dr. Frierson, the things Dr. Frierson wanted, but what type of testing were you going to be doing? What areas were you focused on for Dr. Frierson?
So Mr. Jones has a complex history. We all have seen the head scans of the structural right frontal depression in his skull. So I did cognitive testing to look to see if he met criteria for a neurocognitive disorder or if he had any residual or leftover impact from that would impact his ability to think clearly and make decisions. I also did a psychological profile, which is essentially gathering data or information on behavior and how someone functions, personality aspects. That would be the psychological piece. And then we, of course, needed to assess for the psychosis piece, which was reported. And so I also did that.
Prior to doing the cognitive testing, was there a series of tests you gave Mr. Jones?
Yes.
His ability to take tests.
Correct.
We call those, or I call them effort testing. Is that the proper term?
That's a fine term to call it. So before we assess anyone, we need to know if, because this is objective data, I need to understand how to apply it. Is this someone who is giving appropriate effort? Because if not, if I say this person is in the second percentile or so, was it because they didn't apply the effort, or was it because they couldn't apply the effort in terms of their neurochemistry or what's going on in their brain? And so these tests are somewhat of a screen to see if the data is going to be valid that you collect. Because if you collect data and you use it and you stand behind it, you want to say that it is valid. And so I did that not only with the cognitive testing, but also with the other aspects of testing I did.
How many tests did you give that you classify as effort tests?
So, and I'll reference my report, which I have here. So in terms of effort testing, specifically for cognitive functioning, I administered 3 tests. I relied upon 4.
Yeah. The 3 tests you gave were what?
Something called the dot counting test, the Ray 15 item memory test, and the Ray 15 item recognition trial.
This is just not evidence, but just to assist as we go through this. Doctor, can you kind of explain what each of these tests do and what you're looking for?
Sure. So with the dot counting test, it has something we would say has a high face validity. So it really is just what it says. It's a piece of paper with dots, and we ask the patient to count the dots as quickly as possible. Now, these dots get more complex as you flip through the test, yet they're grouped in ways that we are used to seeing. Like if you saw 5 dots and they were like they would be on a dice or on a set, you would know. You wouldn't have to necessarily count them because you're visually recognizing those. So they get more complex in terms of how they look, but really you should be able to kind of scan through them quickly. And Mr. Jones did just fine with that.
And as to the Ray 15 item memory test and recognition test.
Yep, and I'll be brief in my summary of these. I mean, I could go on and on. But with the Ray 15 item memory test, we present a stimulus sheet with 15 items, and there it would say 1, 2, 3, A, B, C, and so forth. And it's something, again, it looks like a lot of items, but really you can use mental heuristics or shortcuts to remember those. And then after 10 seconds, we ask if the patient can remember what they saw. And again, he performed within normal range on that.
Same true with the recognition test?
Recognition is, now tell me, I take away the stimulus card and say, what do you remember? And he did just fine with that as well.
You said there was a fourth test you relied on. What test was that?
That was a test I reviewed with Dr. Brawley, the test of memory malingering. It's something I would have given had she not given it. It's a standard test to administer prior to cognitive testing. And again, that was within normal range.
Dr. Brawley did this test. She wasn't working with Dr. Frierson,
No,
and she did this test, was it April of 2016?
correct. Now, she has worked with Dr. Frierson in the past.
But for this case,
For this case, she was not
in fact,
associated.
I believe she was hired by Mr. Jones' folks. Is that right?
That's my understanding.
So you looked at that test too. So based on all that, did you determine that Mr. Jones was suitable to continue testing so you could actually test his cognitive function?
I did.
Now, let me see, let's just go into what you did with cognitive testing if we could, and then we'll talk a little bit more. Did you give a number of tests, variety of tests?
Yes, it is considered a best practice to give a variety test. No one, depending on what field you're in or what area you're testing, psychologically or neurocognitively, should you ever give one or even two tests and make an assumption from that.
I've got another list of tests here, and see if these look like the ones that you gave Mr. Jones.
Yes, and up there, yeah, now it does.
Might not be able to get them all on there. You don't have to go into a lot of detail about these tests, but what are you really looking for on all these different tests?
So the way I explain this to my residents, this is a non-invasive way of seeing how someone's brain works. So it's almost in a way looking at, it's not like a functional MRI, but I use that example because when you have someone under a brain scan and you introduce different thoughts to them, you can see how their brain works. And so psychological testing in terms of the neurocognitive performance, it mimics that. So each of these tests are meant to see how someone is functioning or their ability to attend to information, to remember information, not just right then, but also a delayed memory recall, visual spatial functioning. So how well are you able to perceive items, remember them, manipulate them in your mind from a visual spatial perspective. And something that I think you all have heard of throughout this trial, executive functioning, which is that just like what it sounds, it's like it's the executive of your brain, the person who, or the tendency for your brain to execute attention, concentration, make decisions, reasoning ability. So these tests, the reason why there's so many different ones, and even within the tests, there's different subtests, is to ensure that we're measuring all of these areas.
Now, you mentioned there were scans of Mr. Jones' head injury. Mm-hmm. You had an opportunity to review those as well.
I have.
And in looking at that, what was your take on his injury? Was it a significant injury?
It was. It meets criteria for traumatic brain injury, of course. I mean, he has a structural, and as people have pointed out, or experts have pointed out, you can see the skull depression. But a brain injury does not equate to neurocognitive disorder. If it was that straightforward, my job probably wouldn't exist. So certainly it is impressive in viewing, and I think the term in itself, traumatic brain injury, is very scary to people. A lot of times we have something called neuroplasticity. The brain kind of regenerates in areas that's been injured, and we are still, and so there's so much research to be done about how the brain operates, of course, but at this time, there is the understanding that, impacts to the brain can occur, and some people are on the negative side of that, and some people come out and can function back at their baseline.
Is it true you could take a brain scan, just like Mr. Jones, and put up someone else's that's an identical looking injury but have two very different outcomes?
Correct.
So you can't tell the effects of the injury from just looking at a brain scan?
Correct.
Even if you're slicing through the brain, doing a very nifty 3D evaluation, you see injury, but you can't see the effect?
I actually had the opportunity to dissect a brain this summer, and I will tell you the trauma I saw in some of these brains, and then the reports on how, of course, this was post-mortem, so I didn't get to assess these people, but the functional aspects of how they were performing in life, it was quite drastic.
And you actually do work with veterans as well.
I do.
Suffered brain injuries and
Yes, I've seen thousands of veterans with comorbid or occurring at the same time, diagnoses of mental illness and also having some type of traumatic brain injury. And it's one of the things I do for compensation and pension purposes through the VA to assess them and determine if they meet criteria for a neurocognitive disorder or psychiatric disorder.
how did Mr. Jones do on this battery of tests?
He performed very well. In comparison to Dr. Brawley's performance, where she had him assessed as being in the first percentile, and at least 3 of the areas I saw, we went from the first percentile back in 16 when she saw him. In my testing, he was in the 79th and 80th percentile.
When we talk about percentile, if somebody's first percentile, what does that mean?
That if you had 100 people, 99 of those people would do better than you. You would be at the very bottom of the performance ability.
And how was his IQ rated by Dr. Brawley back then? And
In the 80s, I believe.
would that be low IQ or low average?
Lower than certainly his functional abilities would suggest.
Is that one of the reasons why Dr. Frierson wanted you to test this area?
I think that was one of the primary things that stuck out to him, yes.
Because of his background, his high grades, and the profession he was in?
Yes, that was of concern to him. When you conceptualize a patient, like I'd said before, you never take one piece of information and make all of your assumptions on that. And particularly in Dr. Frierson's role in this case was to look at everything. And when he looked at that assessment in the first percentile ranges and what we know for patients functioning in the first percentile ranges, they're not, a lot of them are unable to even drive a car. So this didn't make sense to him. And I think that was the primary reason he asked me to perform my evaluation.
And he did exceptionally well.
Yes, there's a variety of scores obtained, but when the 80th percentile is very good.
So based on that, what was your conclusion as to his cognitive function?
So overall, he did not meet criteria for a neurocognitive disorder based on this evaluation.
So his brain's basically okay? Just in layman's terms?
Yes.
Okay. He doesn't have a broken brain?
Correct.
Okay. Well, let me ask you about, did you learn that, or did you know that back when Tim Jones took his testing with Dr. Brawley in 2016, he was taking 320 milligrams of geodine?
He told me that.
Who did?
Not Dr. Jones, Mr. Jones. He had expressed that to me and had mentioned that he felt very much slowed in his psychomotor behavior, meaning just your ability to kind of move around and function in general, very slowed, and also that it was impacting the way that he was thinking in terms of processing speed in particular, which is one of the main areas that were at deficit in Dr. Brawley's report.
So do you determine, or have you determined that the difference between the testing between what you found and what Dr. Brawley found was based on the medication Mr. Jones had been taking?
That is my conclusion, absolutely.
As opposed to a head injury and it just got better?
Yeah, we would not see a head injury in the first percentile or a neurocognitive disorder of such, exclusive from a state of delirium, that then jumps into the 80th percentile just for any organic reason. There's no research supporting that I know of, or that any of my colleagues
How
can.
did it get better like that?
No.
So it was obvious it was the medication.
That's the biggest explanation the best explanation I can come up with.
And is it important before you test somebody to ask about what medication they're taking?
It is. So I'm not a medical doctor. However, it is my job to understand how my patients are presenting, hence why I give effort and validity testing, and why I have to also understand that day, have you taken anything before this test that will impact your performance? Patients who are regularly prescribed Xanax, for example, I ask them to withhold that medicine before they come in for testing, because certainly that would impact their performance. So the information or data I'm collecting must be a valid representation of their true baseline abilities. It cannot be their functioning influenced by a substance, a prescribed or other drug. And if they've had a good night's sleep sometimes. I mean, I need to know that they're able to give the appropriate effort.
So bottom line, though, although he had a significant or impressive head injury, there was no clinically significant cognitive deficits?
Correct. And that is one of the requirements for the diagnosis of a neurocognitive disorder.
So he has no neurocognitive disorder?
I did not diagnose him with a neurocognitive disorder, no.
All right. Once you moved on from that, what did you test him for after that?
So then we can get into the report of symptoms regarding psychosis. And within that area, I also performed a series of tests looking at symptom validity. So they all fall under the same category of validity testing, whether you call it effort or performance or symptom validity. I mean, if we got down into the definitions, we could get a little more detailed, but I don't think there's a need for that to help you understand how I use these tests. But that is similar, but of course in this area, I'm looking to see if I can have valid information collected based on his self-report. And these tests are meant to look at the range of symptoms reported by individuals with schizophrenia or psychosis, and then it compares the patient's performance to that. So it helps us see if the person is able or is going to give a straightforward account of symptoms, and if those are consistent with known psychiatric populations.
Okay, so you've done effort testing, cognition testing, and so now you're doing testing that involves whether he reports psychosis or
if it falls within a range that would be clinically relevant.
Now, prior to you conducting your testing, had anybody else done any kind of testing on Mr. Jones that you're aware of for this case in this area?
No, I would definitely want to know that. As far as all the history I've gone through, I'm the only one that has done any personality assessment or any testing of psychosis, any validity of how he's reporting symptoms, any testing to rule in malingering. I don't see that anywhere else.
So Dr. Brawley or no other psychologist did this kind of testing?
Correct.
And again, was Dr. Frierson requesting this testing?
Correct. And Dr. Frierson did not dictate the testing battery I gave.
That's your professional call, is that
Correct.
And again, did you give multiple tests?
I did.
Put some more up here. Screen. See SIMS, the SIRS, and the INFAST. Those look like the tests you gave in this particular area.
Yes.
And if you would, could you walk us through what these tests are?
Yep, and again, I'll summarize and be brief. So the SIMS test is, and I think Dr. Dorney testified to this. She had said that was a test that if someone scores high in an area, then it does indicate the need for further testing. It's a structured interview for malingered symptomology. And so it has a series of questions that look to gauge the patient's response in comparison to individuals with known psychiatric disorders that are validated. And so it helps us to see if the person is over-reporting symptoms and also if they're under-reporting symptoms. And in this area, Mr. Jones had performed within normal ranges in all of the areas except for the area of psychosis, which was a score of 6. And just to make this very explicit, I actually copied out of the manual the sentence that goes with the score he obtained. So his score was 6. The manual says anything over a 1 is clinically significant. And this is what it says: even low levels of endorsement of such inconsistent, bizarre, and/or atypical symptoms is highly suggestive of malingered psychosis, even in the rarity with which such symptoms are endorsed by actual psychiatric patients. So to break that down, if you were to know someone, a friend or someone with schizophrenia, and they were to explain to you what it's like to have schizophrenia, that would be a baseline, let's say, of schizophrenia. But this level of endorsement would have been significantly more elevated than that. And
Is this him identifying symptoms that just really don't have any?
these are symptoms that are inconsistent with schizophrenia, yet meant to mimic those of schizophrenia.
Does it mean he has a different type of disorder or psychosis, or does it just means that there's...
Based on his self-report, it's suggesting it's not reliable.
What about the SEERS test, or SIRS test? I always want to call it SEERS test, the SIRS test. How did he do on that?
So again, we're seeing the same theme in this area. This test also breaks down the patient's report of symptoms into different areas. This is purely looking for psychosis. And the areas reported by Mr. Jones to be in the clinically significant range were found to be, let's see, let me just make sure I'm saying this clearly. Rare symptoms, so symptoms, I mean, that's pretty self-explanatory, that are rare within psychosis. So symptoms not typically endorsed by individuals with schizophrenia or other psychotic disorders. Symptom combinations, that was another one that was in the clinically relevant range. So it takes symptoms that may be experienced by patients with known psychiatric disorders, and then it puts them together. Like, when I hear voices, I lose a lot of weight. That's not a specific example, but just two things that might be reported, but that are usually not reported together. And then also, this is the category, improbable and absurd symptoms. That was the highest rate of responding, and the test found that to be in the definite range of malingered symptomology. And the other two I just mentioned were in the probable range.
So as far as the range of malingering, finding malingering, you had one range that was definite and another is probable?
2 that are probable and 1 that is definite per this test.
How about the MFAST? How did he do on that test?
That test also yielded a significant score for the likelihood of malingering. He had, the highest score was in unusual hallucinations. So the report of hallucinatory experiences, so the visual or auditory symptoms. And in this case, it looks at all kinds of symptoms. So any sensory experience you could have could be, some people have tactile hallucinations. It's very rare. Olfactory hallucinations, where you smell things that are not there. Gustatory hallucinations. It goes down all of the senses, especially. But in this test in particular, his score was significant in unusual hallucinations. Extreme symptomology, so his report of symptoms was beyond that individuals with schizophrenia would typically respond to. And also an unusual symptom course. So if you look at symptoms over the course of time, his report of symptoms did not match up with those individuals with known psychotic disorders.
Your report has something that says highly suggestive of malingered psychopathology.
Correct.
So all 3 of these tests show that there's malingering.
Correct.
Now, while you're doing these tests, how long did y'all spend testing?
8 hours.
Did you take breaks?
We did.
Did you have an opportunity to talk to Mr. Jones throughout this process and kind of build a rapport with him?
I did.
Did he at some point talk to you about the types of things he was seeing and make movie references?
He did. He explained that the visual permutations, you've heard that word in this trial, or the visual, atypical visual experiences he was having. He described it like the movie Dumbo, about the pink elephants on parade. There's a part of that movie that has a very odd visual piece to it. And I did look it up. It's because I remember watching the movie as a child, but I didn't remember that part. And it's an odd video. I mean, it's an odd part of the movie. With
Had any patient or anybody you're testing make reference to that to describe what they claim they're seeing?
no,
Did he make reference to another movie to describe this situation?
yes, A Beautiful Mind.
Is that with, was it Professor Nash, the schizophrenic Nobel Prize winner?
Correct.
Did he relate to that individual?
That was his comparison.
But in doing these tests, did you find any evidence that he suffers from a psychosis?
My testing data did not suggest such.
And just as with cognitive testing, you're asking about medications and all, there's been some question brought up about when you would do testing to determine if somebody has psychosis. There was talk about somebody might need to be in a psychotic state in order to do that testing. Can you test somebody when they're in a full psychotic state?
I think it would be very apparent if someone was in a full psychotic episode, and certainly no testing data, if you were trying to look at baseline behavior or cognitive functioning, would be valid in that regard. These tests, particularly the ones to rule in or out malingering, are normed in population. So these are not tests that I came up with. These are not tests that you research online and you can find and take yourself. These are copyright materials. These tests are based in psychometrics, neuroscience. They are normed across populations, thousands of individuals, to look at what is a normal base rate of behavior, and it compares the patient's performance to such to help the doctor determine if this person can give appropriate effort. And so these are scientifically peer-reviewed testing measures. To make a comment like that suggests someone is not competent in psychometrics, and is also, it just explains that maybe someone who makes that comment doesn't really understand how the tests are used or how they're developed.
And unlike psychiatry, this is, since it's scientific testing that's used all over this country, you could go into any courtroom and testify using these tests and everybody know what you're talking about.
Part of the reason why I do what I do and I feel comfortable on the stand is because it's not, I'm representing the data here. The data speaks for itself. And so, yes, that is correct. These are the way the information is collected is standardized, and the way it's scored is standardized. So it really takes out, I mean, I wish I could say I'm the one, I'm this brilliant person coming up with all of this, but it's the test. So the test itself gives us the information.
So this is, just to put it in very simple terms too, not only scientific, but it's very objective testing.
Correct. That would be the appropriate word.
What Dr. Frierson does as a psychiatrist, by talking, doing interviews, there's a greater level of subjectivity to what his field is.
I believe he derives his opinion based on collecting information and history and looking for patterns. Mm-hmm.
But I think he mentioned, just for instance, that sometimes two psychiatrists can come to different conclusions.
Yes, that's extremely common. I think, as you all have seen, there's research studies and articles that speak to such, that the subjectivity in clinical interviews at times can be up to a rate of a 50% error rate because of the subjectivity involved. And I think that's one strength of my field, that we're able to provide objective testing data to help support or not support diagnoses.
Is that one reason why it was so important for him to partner with you on this testing?
I believe so.
That assisted him.
Correct.
So at the end of the day, you have no organic cognitive defect. You have no organic psychosis, no psychosis.
Correct.
And you did find malingering.
Correct.
Now, you mentioned some more testing. What did you move on to after this?
So in layman's terms, personality testing. So testing of behavior and helping me understand how he thinks, what his attitudes are in life, how he approaches problems.
And I believe you gave 3 tests.
Yes.
The MMPI-2, the MCMI-3, and the PAI protocol.
Correct.
Now, can you tell us what you're doing here and what you're looking for here?
So these tests, again, personality measures, they also look at what we, in the past diagnostic and statistical manual, referred to as Axis 1 disorders or depression, anxiety, that type of thing. But generally, these tests are helpful in understanding how people go about life and what they might be like in terms of personality and how they might cope with problems or stressors. The nice thing, too, about these tests is they have built-in validity scales themselves. So you wouldn't have to administer, like I did with the psychotic testing or with the cognitive testing, symptom validity tests prior to this. They themselves tell you how the patient approaches the test and how they have responded, and they pick up on patterns.
Can you walk us through what you did and how he fared on these tests?
Sure. So on the MMPI-2, which is why it's I think in our country and also in Canada the #1 used test in forensic settings to gather information, highly respected in my field, highly valid, highly reliable test. He scored a 65 on the L scale. He scored a 74 on the L scale and the cutoff score for that is 65. So what is that telling me? He scored beyond the range of what we would want to see in terms of looking at if someone is a reliable historian or if they're able to provide information in a way that would be similar to their true baseline. So within that test, I had to take that into account.
What's another name for the L scale?
The lie scale.
So he 65's the cutoff, and he scored a 74.
Correct.
And what else? I'll cut you off. I think you were still talking about what you were doing.
Well, I was just going to report on what he had reported, because this is one where it's true-false questions, a lot of true-false questions. And so you go through and you say true or false to questions. And those questions, as we're not going to get into the specifics of the questions. Those are actually, you don't ever look at the specifics of the questions, even though I know that's been done, not in this case. But the way he reported symptoms revealed his report of persecutory ideas, self-consciousness, social discomfort, emotional alienation.
Self-reports.
Correct.
Okay.
Yes, schizotypal characteristics. I mean, that was how he was responding to the test. Those were the areas that came up.
How did he do on the MCMI-3 test?
So again, looking at the validity scale built within the test, I found a high degree of self-revealing inclinations. So over-reporting of symptoms in that regard. And within that scale, again, similar findings. Anxiety was highly elevated. He hit on a number of personality traits across almost all personality that we would say found within personality disorders. So it was somewhat difficult to interpret because you normally don't have someone with, let's say, who is significantly withdrawn, but also an extrovert, or it was just difficult to interpret because of the dispersed symptom report.
In layman's terms, was it just a hodgepodge of symptoms he was identifying, saying that he had?
That would probably be an easier way to say that. Thank you.
And none of those really related to one another? Some of them were even contradictory?
Correct. And certainly we all have different aspects of our personality. I mean, maybe in some situations you might feel more comfortable to be outgoing. And so it was not, the test was not completely invalid. It just helped me understand how he sees himself. And so that there may be some, I'll use your word, like the kind of a hodgepodge of personality traits or characteristics that are at play in everyday life with him as he experiences the world.
About the PAI protocol, how did he fare on that?
So this one was interesting to me. So again, back to the validity scale, which is the first thing I look at before I interpret any data, as you can see, across any domain I do of testing. In this case, not only was overreporting found, but underreporting was found. And in the area of underreporting, it would be that he would not admit to things that most people will admit to. That people don't want to quickly get up and say that they do, but they probably might do. So a good example of that would be, have you ever left the bathroom before washing your hands? I mean, it's not the first thing you might want to tell people that you've ever done in your life when you meet them. Have you stolen a cookie from your grandmother's cookie jar? Things like that you might not want to admit to. Well, his defensiveness in that regard was very high, and so there was an underreporting of symptoms in that regard, yet an overreporting of symptoms in the area again of psychosis, or in that area where you might have difficulty with what we call reality testing.
Based on these tests, can you determine if there was anything that you might describe as malingering, or how would you describe it? Or is malingering even part of this type of test?
I think it's more, so these tests are not for malingering, but these tests do represent a pattern of behavior similar to that found in the earlier testing we discussed of a tendency to overreport symptoms, a tendency to maybe underreport shortcomings that are even normal shortcomings that we all have. And I think the most important piece to all of it is, can we look at this person as a credible historian? And so based on this testing, this is saying no.
Now, were you able to, after this testing, develop some impressions, clinical impressions of the work you had done with Mr. Jones?
Yes.
What are those?
So overall, criteria is not met for a neurocognitive disorder. So while we do have history of TBI, there are no findings on my neurocognitive assessment to suggest that cognitive impairment impacts daily functioning, or that even within the frontal lobe functioning, that this is a person who would have difficulty reasoning, engaging in judgment, planning, executing multi-step behaviors. I didn't see anything there to represent a deficit. Beyond that, there were some atypical personality findings, as I discussed. Once I kind of looked at all of the data together, I think the thing that stuck out to me most was more of an antisocial and borderline personality.
What is borderline?
It's someone who sees the world very much in black and white, someone who has a significant fear of rejection, abandonment, disapproval. They're very quick to react to even perceived slights from an interpersonal perspective. These are people that have mood swings very easily throughout the day, and those are based on external triggers. Usually those that are interpersonal, and it's usually prompted by any sense of rejection or abandonment. Borderline personality historically and per data does have a strong pattern of individuals who engage in self-mutilation or cutting behavior on themselves. I know that was mentioned in the history, yet I believe Mr. Jones denies ever doing that.
Did you make a full diagnosis on borderline, or is he just
No.
traits?
Correct. He did not meet criteria for any specific disorder, I should say. Yet there is a diagnosis of unspecified personality disorder, and that's kind of like what you had mentioned with the hodgepodge of symptoms. So when we have clinically significant symptoms in multiple areas across different disorders, yet all the criteria are not met for such disorder, we come up with unspecified, which means, yes, there's something there, but all of the criteria are not met.
You mentioned antisocial. What is that?
Someone who has a tendency to not observe regulations of society, laws, lack of empathy for others, more inward focused than outward focused in terms of self versus others.
So those traits were present as well?
Yes.
And back to borderline, how does that differ from, say, bipolar?
So in our society, those two are commonly interchanged, yet they are very much different clinically. People I know, that he's so bipolar. People often use that term to say, any little thing will set someone off. That is not bipolar disorder. Bipolar disorder occurs when there's an innate or organic process going on. It's not driven by interpersonal stressors. The borderline process it's the person who in the same day might look different in regard to mood, and their ability to regulate emotions in the face of interpersonal stressors is extremely poor. They might have episodes of rage, whereas bipolar disorder, you would see mania, disorganized behavior, someone who it looks like almost a different person, and that would last for several days to weeks, and that's also accompanied by severe depressive episodes.
With borderline, have you ever heard it described or had any patients or clients describe it as something to the effect of, I hate you, don't leave me?
There is a book written, and it's since been revised, and that's exactly the title, I Hate You, Don't Leave Me. And oftentimes, when I've had borderline patients and they know about that book, they'll say, my relationships are like, I hate you, don't leave me. It's this turmoil of, this fear of rejection, of abandonment, but then also just the difficulties within the relationship and lots of fighting and against each other. Yet the makeup period kind of meets all the needs that the person wants, because it's the opposite of the fear of rejection or abandonment. So it's almost like they create that in their lives at times, significant turmoil. But yes, that is a book written by, I believe, psychiatrists working with patients with borderline personality disorder and their experiences of such.
Now, even though you found these traits and you've got a personality disorder unspecified, is that the same thing as psychosis or being psychotic?
No.
Personality disorder, again, is what?
So it's a pattern of maladaptive behavior over the course of time that is typically seen in the way the person interacts with people and interpersonal functioning. So it's something that's over time. It's usually developed, a lot of them, in difficult childhood experiences. I mean, in this case, if we're finding the borderline personality traits as being very strong, it makes sense that there is likely some sense of rejection or abandonment earlier in life that fits in terms of the clinical conceptualization.
It has nothing to do with psychosis.
There can be dissociative periods in borderline personality disorder, but in that regard, the person would meet full criteria, and that is not the same as hallucinogenic psychosis.
There's no evidence, though, just stepping back from this case, of schizophrenia?
Not per my testing or the history I've reviewed, no.
Schizoaffective disorder?
No.
Bipolar?
No.
No psychosis whatsoever?
Correct. Outside of possible substance-induced psychosis.
Let's talk about that.
Mm-hmm.
With substances, that's voluntarily induced drug intoxication?
Assuming the person took the drug voluntarily, yes.
But that is short-lived once the drug wears away?
Correct. And looking at the history, you wouldn't have schizophrenia occurring over the course of 24 hours, at a 100% rate, and then the next day not have it outside of an intramuscular injection of, that's not a typical course of psychosis, no.
Of course, the voluntary consumption of drugs or alcohol, that's not a defense.
I'm sorry, I couldn't hear you.
Voluntary ingestion of alcohol or drugs is not a defense in court.
I am not an attorney or a lawyer.
What action?
I don't know what is or what is not a defense. It's not found in my testing, and I don't know how to test for that exactly.
Okay. I think that's pretty much all I've got for you right now.
Thank you.
Answer any questions the defense has.
Of course.
Sure. How long you need?
Just 5 minutes to get my notes together.
You want me to have jury step out?
They don't have to.
Okay, well then take your time right there. It's fine. Oh, I don't have any. About the tissue. Danny's needing some. Give that to the menu, fine. Okay, if she needs to go, y'all can step out then. That's fine. You can talk about the case, right back in here. When y'all ready to come back in, let me know, because we'll have to go back. I'll pass them over there, as I have.